Hi everybody and welcome back, and apologies that we had some technical issues at the end of that last session, but we think everyone's fixed now. I'll just there was a message I was meant to give you at the end of that last session. If you haven't yet voted for your best presentation, then please do so before 12:30, and the best presentation award will be given at 1 o'clock. So welcome back to the final session of this year's conference. We have a panel of health sector leaders who will be discussing clinical and strategic improvements in healthcare through activity-based funding. And particularly welcome Janice Peterson, who will be introducing the panellists and facilitating today. You'll recognise Janice. She's a journalist who's worked on a number of platforms and a presenter for 2 decades, and currently presents SBS World News 5 nights a week. In her current role, she regularly interviews leading newsmakers and has contributed live updates on major national and international news stories, including rolling election coverage in Australia and the United States. So thanks very much for joining us, Janice.
Absolute pleasure. Well, good morning, everyone, and welcome. My name is, you've just heard, I'm Janice Peterson from SBS World News. I'm joining you from Sydney, and to acknowledge the Gadigal people of the Eora Nation as the traditional custodians of the land from where I'm joining you from. And I extend my respects to the elders past, present, and any First Nations people joining us here today. It's my great pleasure to be hosting this panel discussion. Again, as you've just heard, we'll be discussing clinical and strategic improvements in healthcare through activity-based funding. I know there's a lot of interest in this, so I'm really looking forward to what our esteemed panel has to say. And on that note, let me introduce them for you. It's Professor Claire Jackson, AM, Professor in General Practice and Primary Care Research and Director, Centre for Health System Reform and Integration, University of Queensland. Professor Claire Jackson, AM, has been active in integrated care innovation, education and research since the early 1990s. And much more recently, extensively involved in health services research and reform. She's been a member of all 4 national primary healthcare strategy and reform reference groups, really guiding forces behind Australia's national health reforms agreements. Professor Jackson's current area of research is health system reform involving primary care, a topic on which she's published and presented internationally. So she's full bottle on this. So thanks again for joining us.
Thanks, Janice. Delight to be with you today.
Wonderful. We also have Associate Professor Alistair Mcdonald, Chair, Clinical Advisory Committee, Independent Hospital Pricing Director of Medicine in
Clinical Associate Professor at the University of Tasmania.
Now,
As a physician,
he has a small private practice. He's also the Chair of the Clinical Advisory Committee to the Independent Hospital Pricing Authority and a member of Healthcare Homes Implementation Advisory Committee. We welcome Associate Professor Alistair Mcdonald.
Thanks, Janice. It's good to be here.
Also joining us today is Mr. Ross Sinclair, Deputy Chief Financial Officer, New South Wales Health. Ross is currently Associate Executive Director, System Financial Performance and Deputy Chief Financial Officer for New South Wales Health. Ross has extensive experience in both private and public sector roles and really running a full gamut of all different things from banking, manufacturing, aerospace and health. Ross is currently the National President for IHACPA, also the current New South Wales IHACPA Chapter Chairman. So g'day Ross, and thanks for joining us.
And it's lovely to be here with everyone today. Looking forward to the session.
Okay, yeah, so wonderful to see you all there. Now, I should just mention that we are also hoping that Professor Christine Bennett, AO, who's a former Deputy Vice-Chancellor, Enterprise and Partnerships at Notre Dame University. I won't go into her full bio, but we're hoping that she will join us at some stage, but she's just not on the call at this very moment. I would love to start by asking the panel about this particular model, activity-based funding. Any model, I guess, it doesn't matter what it is, it should act as a lever to improve efficiency, effectiveness and quality. So how is the activity based funding model tracking, particularly in those areas. So who'd like to kick things off?
I'm happy to talk a little bit about it. I mean, as the chair of the Clinical Advisory Committee, it's one of our roles to make sure that the model delivers in these areas, and certainly from the point of view of improving efficiency and quality. The innovations recently, in the last couple of years, looking at quality of care through changes in the way we fund hospital-acquired complications, changes in the way sentinel events are funded, and the impact of readmissions has certainly helped with the quality aspect of this. One of the other things that occurs as a result of the model is that there is a significant improvement in the data that we're working with, because the coding data is required for recording the activity. We now have a much more consistent data set across the country as a result of much better coding that's come from this process, and that allows us to monitor efficiency much more effectively. There's also benefits in consistency of practice that comes out of these sort of models, because of the way in which the coding and the data is collected. It brings greater consistency of practice across various jurisdictions, not just within the jurisdictions, but nationally, in the way we deal with particular diagnoses.
Anyone else wanting to chime in there? Ross?
Yes, absolutely. So ABF has been an absolute feature of our system. I mean, in our quaternary services and across all of the health landscape, we have a really mature clinical review type process. So as Alistair mentioned, the data is really important, and the comparison of how we look across jurisdictions is important. So really, as we've matured through our system design, we've been able to really improve that lens, and so that has really success around the system in really connecting up clinicians and people who can come together and talk about difference, and then have a conversation about how we might remedy that. So in terms of where we're at, the consistency of practice message that Alistair gave is a key ingredient to the system. And it's not just about volume, it's about all of the other systems that sit around the model for clinical outcomes and best practice, because after all, we're here to deliver the best healthcare for the citizens that we serve. And the model has been a terrific innovation through time, and enabled the system to be able to have those really important conversations, but more importantly, the outcomes associated with how the models.
Well, on that point then, of course, measurement is very, very important to delivering those good health outcomes to the people that you're serving, as you say. Are there quality metrics in place to ensure that that measurement is happening in an effective way? Claire, did you want to?
Yes, and I coming from Queensland, I'm acutely aware of the Dr. Death scandal many years ago, which showed that if you are only paying for activity and not looking at other indicators, you can do a lot of damage. And I completely accept Alistair's comment. A lot of work's been done over the last 15 years to look at the quality of what's being purchased, and particularly in New South Wales, looking at high value outcomes. That's really emerged as a big area over the last few years. I suppose the big criticism still is that we're looking at helicopter level measures, which are very important, but measures close to the patient, close to the provider, are much more challenging. I think that's an area we need to do a lot more work on in the next 10 years. The other area I think we need to be looking at is rewarding activity relevant to patient outcomes across sectors. And obviously ABF is very much used as a financing for state-funded care, but we have a lot of care delivered in primary care and private sector community care, radiology and pathology in particular, and also 47% of Australians have private health insurance. So there's a lot of activity that happens in the private hospital sector. And I think probably one thing we would like to see over the next 10 years is starting to look at activity across the continuum and following funding around activity across sectors rather than looking purely at one sector. And that's hugely challenging, but I think that's something to be called out at this conference and look at potential manner of taking that forward.
So, Claire, in relation to ABF then, what are the key limitations of ABF from a primary healthcare and general practices perspective?
So if we're talking about the big challenging areas, ageing, mental health, chronic disease management consume more than 50% of health resources, those are areas that really need a continuity of care model. And the quality of care obviously is directly linked with the amount of resourcing that sits behind it, both in terms of person power and also infrastructure funding. So I would like to see us looking to use levers such as the health reform agreements, the 10-year plan, the health workforce 2022-32 reports that are out, and also the opportunity that IHACPA has via prosthesis reform in the last budget to be really looking a lot more strategically at rewarding activity at the patient level and linking that activity at the organisational level with what's happening in other sectors and also at a more granular level close to the patient.
Ross, just following up from what Claire's saying there, I suppose one of the main concerns about this type of model is that there could be a danger in incentivising volume over quality of patient care. We hear that sometimes when we talk about this ABF. How do you ensure that the ABF model isn't leading to a type of churn mentality in the hospital system where the cost benefit of getting patients in and out quickly becomes a major driver?
So thank you, Janice, and thanks, Claire, for that wonderful commentary. In essence, as a system, we continue to work hard. I mean, what COVID actually taught us, I'll use COVID as an example, is that we can actually work across agencies and sectors to be able to bring this all to you know, some really fine structures in place. In New South Wales, we've got 17 districts and networks that really come together in a coordinated way. And so we've got a clinical governance framework which sits up and down the system. The clinical councils of all of those districts and networks come together to look at clinical quality and value of clinical quality through their committee structures. The boards also in New South Wales have a really keen interest. We're designed as a system with clinical safety committees at board level. So all of the work in the system comes together, and as was mentioned earlier, all those sentinel events, all of the clinical stuff is discussed there. So as a system, it's a continual process of review and measurement around performance and really honing in on the areas that we need to address.
Thank you. I'm just unmuting myself here, and very, very pleased to see that Professor Christine Bennett has joined us. The technical gremlins have been ironed out and obliterated. So Professor Christine Bennett AO, former Deputy Vice-Chancellor Enterprise and Partnerships from Notre Dame University, Emeritus Professor Christine Bennett AO is the former Deputy Vice-Chancellor of Enterprise and Partnerships, was Dean at the School of Medicine, Sydney, for more than 10 years at the University of Notre Dame, Australia. Professor Bennett is a specialist paediatrician and leader with over 40 years of health industry experience in clinical care, strategic planning, business operations, executive management in the public, private and not-for-profit sectors. So thanks so much. We are delighted to see you here.
Thank you very much, Janice, and thank you to all the people in the background who've spent the last half hour trying to keep me on. And also, could I acknowledge the traditional custodians of the land I'm meeting on, which is the Cammeraygal people of the mighty Eora Nation. And yeah, great apologies being late to this important discussion. Yeah, happy to contribute in whatever way. What would you like me to cover?
Oh, well, we're really glad to see you there, Christine. We've just covered some areas around performance of ABF and also how we're probably measuring whether it's working or not. So there's still 45 minutes left. So
well, look, if I can make a couple of comments, if I could,
of course,
about the strategic intent. I feel a bit like the godmother of ABF and IHACPA. With having chaired the National Health and Hospitals Reform Commission that recommended that we move to this very important platform of financing of hospitals. And I think it's important. I noted in the commentary that this is contributing to efficiency, to quality, to outcomes, but also it was to provide a transparency and an ability to compare and ensure fair funding, but align Commonwealth and state interests by the Commonwealth having a risk exposure to hospital activity. And I think that's a really important point, because we now, I think, at a new era where we really need to now glue what we're doing together in hospitals with what's happening in the community in integrated care more completely. So I just wanted to say it's an important tool. It's not a religion. It doesn't cover everything, but there's many more applications of the data that comes out, which I know is part of the intent of this discussion. But we're on a journey, and I think you're just talking about COVID. I think COVID has created a little break point in that what's been happening in hospitals for the last 2 years. We've had to change priorities. The volume, normal volumes are completely changed. So, I think it's a really important opportunity for a bit of a rethink and a look at where to from here.
So, Christine, with that in mind, are there examples, do you think, in medical service provision where ABF would not be an appropriate model of funding?
That's a big question. I think there are some challenges that we have. Obviously, there's a lot of really important healthcare that we need to have delivered in outside of hospitals, even in hospitals, but as outpatients. So the ABF tool covers, only a segment of what's done. But even in that segment, if I can take an example of continuing research, and I've got an example from the Sydney Children's Hospital Network, which I chaired for 7 years, called Zero Childhood Cancer. Now, that's a research project that's now being normalised into how we deal with rare childhood cancers using data from all around the world, but it takes a different contribution from the clinical team, different time, different, the drug regimes are differently determined. And so you need to have ABF have the agility to code and to cover the costs of those activities as they move from research to actual activity. So, I think that would be one example. I will also say that, having been chair of Sydney Children's, that when you're looking at an internal market, if you like, such as New South Wales Health, ABF also gives you a language and a currency, if you like, for performance agreements and to set volumes and targets and have a conversation around the funding, which my colleague there, Ross, might have views on as well. It's not the full answer, but it's a really important tool. So I think, I could keep going, but I'll be guided by you, Janice, as to what you want to cover. I will say though, you were just saying, are there, clinical governance and supporting clinical governance is an important opportunity as well, with clinical practice analytics at the team and the hospital performance level. Mm-hmm. And can I just say, with the abolishing of NIPA some years ago, the metrics, yes, there are measurements there, and others could speak to this better than I could in terms of the currency of this. But it's really important when we're looking at health system performance to look across the whole system and across all the domains, including in mental health and aged care and others as well.
Thank you so much for that. I'm just wondering if any of our other panellists wanted to add something there.
Yeah, probably I'll just follow up on Christine's comments. Good to see you again, Christine.
Finally.
It is horses for courses. So I think if you've got an 18-year-old with acute appendix to be removed, then ABF is a perfect model. If you've got an 84-year-old with an early dementia living in a caravan park with a lot of other comorbidities, requiring very complex care over time to maintain her in the community rather than in a much more expensive environment, then I think the activity and remuneration and measures need to be much, much broader than they currently are.
And Claire, I know that yesterday from some of the international speakers, they indicated a move away from ABF. I mean, do you see a chance that Australia might be ready to move away from this funding model?
Yeah, and that's probably a good follow-up question to my previous comment. And those are for issues like bundled care for palliative care or maternity care or episode of care funding, where you would look at a particular period of time or clinical pathway involving 3 or 4 different settings or practitioners and look at what's the outcome we're looking for here, what resources are needed, and who's best placed to deliver it. And we've certainly seen competition coming in to sectors internationally. So I think Australia's up for that discussion. I think it'd be really good to get some initiatives rolling and understand them, look at their scalability, and each state and local area has different capacity, particularly in Queensland. What's possible in Brisbane, what's possible in Bamaga are very, very different, and the styles of care delivery would be very different. But I think it's time and would be wonderful to see IHACPA progress some of that discussion.
Ross, can I bring you in again? We heard Professor Bennett mentioning the importance of metrics, of course, but given the launch of the IHACPA National Benchmark Portal, what role do you think that can play to improve transparency?
Look, I think that we just need to make sure that when we're presenting public information that we have a really good education profile. Transparency is everything to support the health and well-being of our nation. So, you know, any way that we can achieve that is a good way forward. We just need to be cautious and careful when we're presenting information that it's actually not going to provide a disincentive for our clinicians, our wonderful doctors and nurses and that work around the system. But I'm supportive. In New South Wales, historically for New South Wales Health, we've had the ABM portal, which has been a wonderful tool that's enabled us as a system to really look across inside out the system and report out to agencies and others our performance. So I think it's a good thing, but I think we need to be considered around, you know, some unintended consequences of some of that stuff if we don't get it right. So we're on a journey and it's a great journey to be on. We just need to be cautious with.
Alistair, how do you think the journey's tracking? Is there enough transparency?
I mean, I think Ross is correct. I think, you know, it is something we do cautiously, and we use it in conjunction with other aspects of information, things like the Atlas of Healthcare Variation and those sorts of tools when we use the portal to look at this. I'd just quickly like to go back for a second and just say that I think that the IHACPA is, and the Clinical Advisory Committee particularly, is looking on a very regular basis at alternative funding models. And I personally have an interest in admission avoidance. And as you might imagine, that is more difficult to fund if you're under an ABF model if there isn't an admission. But we are looking at how our hospital doctors can get into the community under either Tier 2 or other funding mechanisms to help with admission avoidance. And I think the look at sort of bundled and potentially some component of capitation type funding in the future is something that that the IHACPA is open to discussing, and it's a regular agenda item at our clinical advisory committees to look at how we can extend and integrate across the continuum of primary health and hospital health.
Sorry, thanks so much. Yes. Of course, jump in.
Sorry, Janice, just on the back of what and particularly what Christine was saying before, it is important that as we look across the horizon, that we do join up, you know, all of the life cycle of how we provide our care, from primary care, community care, you know, mental health, drug health, population health, in through the acute, subacute and outpatient sphere. That is the future. That's what we all value-based care is something internationally that, you know, is really taking off, and you know, what are the benefits for our patients? Put the patient at the centre of everything we look at. You know, leading better value care has been something that we've looked at over the first few years. You know, renal supportive care, helping our clinicians, our patients and families make really important decisions about end of life treatment, and you know, whether we palliate or we go from renal palliation delivery. So, you know, the system has really thought about this and continues to think about it. And I think Claire mentioned it beautifully at the beginning. It's something that we need to really turn our minds to in the next, you know, decade or so.
I'm hoping that we can talk about the future in more detail, but I suppose it doesn't matter what sector, industry, business you're in, we are going to have to rewind and you know, look seriously at the past couple of years, which have been really challenging. And you know, it's a life and death situation for some people. Unfortunately, the impact of COVID-19 for 2 years has been terrible. In addition to a move towards virtual models of care, are there any other initiatives that you expect to see implemented in response to the changes in service delivery?
Yeah, well, sorry. You know,
go ahead, Christine. Thank you.
Well, I was going to say, you know, we're going to have we already have major changes in how our health workforce operates, and indeed significant health workforce challenges. Not just in the acute sector, but also in the subacute and aged care sectors as well, and the community. So I just wanted to harken back. It does answer this in part to what Claire was saying and Ross, because ABF, or activity-based funding, has a role at that Commonwealth state level, at the state internal market level in terms of how they allocate funds, and then at the local provider level. What the next era should hopefully bring is the ability to, as Claire called it, bundle, and there are other mechanisms that could be used, but it comes down to the funding sources, the Commonwealth, the state, the person's out of pocket, and how they can be integrated. So I think with COVID, you know, we've had to reprioritise. Even the delivery of what we do is different. The public health measures, the PPE, the virtual in combination with face-to-face care. I don't know where the cost accounting and the what we think we've been doing the last 2 years is, you know, ready to set us up for the next forecast. People might be able to comment on that. But to me, this is the time to say, okay, what more can we do to bring the funding together to reduce the silos and to have the person getting the right care in the right place at the right time, and not to incentivise, you know, going to a particular solution because that'll bring in the greatest revenue. And by the way, I don't think hospitals do turf people out to bring them back in again to the ABF. I think that's a theoretical. I think the demand and supply and the challenges of demand are such that that's not front of mind, to be honest, in health services. But anyway, that's just an opinion from, you know, being at the front line, I guess.
So could I just follow up on that point, is that you're right, during COVID, we did unimaginable things. As Minister Hunt said, we moved telehealth further in 10 days than in 10 years. And that was not just organisations and clinicians, that was our patients as well, really embracing the opportunities around access and also around their own personal safety. I think our biggest risk is that we're all going to settle back comfortably to where we were 2 years ago and go, oh, thank goodness, now we can go back to doing it the old way. And unless our KPIs, our resourcing and our funding incentivise staying with what we worked through during COVID and working across sectors and across governments, then we're going to lose a lot of the gains that were made through COVID. I mean, awful things happened, but boy, the health system kicked efficiency and access forward at a rate that was quite extraordinary. So virtual care is here to stay. That does give us an opportunity to work across sectors. But if we're going to do that, interoperability of our systems and secure messaging need a real kickstart. And certainly New South Wales leads the charge with Lumos, being able to connect and share data across all the settings. That makes it so much easier to plan and resource. But I think there's a lot of catching up in many other jurisdictions.
Ross, I've seen you nodding in furious agreement with Claire and Christine.
It's such a wonderful insight. I mean, COVID has taught us, it's really illuminated across the system the opportunities, and we have fast 10 years in terms of our digital technology, the way we engage patients, the way they come into our services, the way that the patients receive ongoing information. You know, virtual has been a game changer. I mean, we had quarantine programs around the country, and in New South Wales, you know, we dealt with drug health, mental health, obstetrics, we dealt with, you know, chronic disease, cancer, and a whole range of, you know, disease groups in quarantine via virtual. And we realised that not only does that provide, you know, a huge relief to our, but if you think about where virtual's going, it is about the patient being at the centre, making sure that, you know, the patient outcomes, and obviously if people need to come to hospital, they need to come in. But we've learned, and our medical teams have been amazing, they've really adopted or picked up virtual well through the burning platform that was COVID. And the other big learning from my perspective was we have this, with an ageing population, technology, the assumption that they'd find it difficult. Well, actually the inverse was true. We found that, you know, elderly people really got on board with technology. And so we do need to leverage, I think, you know, Claire's mention of that we need to harness is really important. And remember, virtual, you can build a virtual footprint for a lot less money than a big tertiary hospital, but your reach is, you can reach thousands of people from a small footprint. It's lower cost. So we need to think through as a system how a 24-hour model like that might work. It's an amazing opportunity.
Alistair, obviously, COVID, this global pandemic has brought up a lot of changes and challenges, but it has fast forwarded and really sped up some things that are working.
Yeah, certainly.
Did you have something to add?
Yeah, no, certainly. I think, you know, as a change agent, you know, particularly for our medical staff, but for, you know, for a profession that is sometimes change resistant, COVID has been an enormous benefit. I mean, there are other tragic circumstances, but, you know, for instance, an example, 10 years ago, I was involved in a trial of the remote monitoring of patients with obstructive airways disease, taking you know, data from their remote to the hospital, and, you know, getting physiological parameters sent in, you know, being able to look at realistic data on their lung function, etc., and you know, and we, you know, it was published and it showed very good outcomes, but, you know, it wasn't taken up because, you know, it was a step too far at that time. And yet, you know, 10 years later, with COVID as a change agent, it's now mainstay of care of most of these patients, in so much as we're now monitoring them in their home. We're able to reassure them, have telehealth consultations with them, and reduce their admission rates by significant amounts as a result of being able to monitor their condition much more effectively in the home environment. And as Ross said, I think the thing that we've found so staggering is that, you know, we comfortably sat back and said, oh, it'll be too much for our elderly population to deal with all this technology. They have adapted enormously well, and in fact, you know, they've shown themselves to be potentially drivers of change once they've got an appetite for this sort of process. So I think, you know, COVID's had its problems, but, you know, and they remain enormous. But the capacity of it to be a change agent in the way in which we deliver care deliver help for care in the community has been one of the really big benefits. And certainly working clinically during the last 2.5 years of COVID, it's been a very much a can-do approach in the organisations. I mean, everybody's pulling in the same direction. The silos, are significantly more cohesive than they ever were in the pre-COVID period. Cooperation and the sense that we're all in the same race has been a significant aspect of the last couple of years.
And to push along on the theme, we're all excited about virtual. The e-consultant initiative we've been running as an integrated care initiative in rural remote Queensland, but also in urban Queensland, sees a general practitioner who's come to the point where they'd be considering outpatient referral, instead sending secure messaging, asynchronous request for advice to a remote e-consultant who within 72 hours responds to that advice. And we've reduced our patient attendance by nearly 80%. Not only that, from a workforce point of view, our e-consultant can be in Japan, she can be watching the rowing, she can be at home at 9 o'clock at night having a coffee, hopefully not a wine, and is able to adjust her work demands 24/7 to what works for her. And so we've had a lot of interest from our consultants, as well as a large number of general practices, in assisting their patients and also their work satisfaction and enjoyment with a model such as that.
And Claire, I think, you earlier said, we don't want to go back to the way things were, and I don't think we will, but we do need financing models that support the new ways of working. And I think that's the challenge, because, the cost modelling, if you like, of the delivery of virtual care and these new hybrid ways of working will need a rethink as well. And similarly, the value-based care. And can I throw in a slight lateral thought? But I think you were mentioning sustainability, but environmental sustainability is a huge issue, and healthcare and hospitals in particular are massive contributors to our carbon footprint. And so there's all sorts of new horizons that we need to consider in how we finance, how we incentivise, how we measure outcome, as well as the productivity of our health system. And I'll throw in aged care, just to say that I think IHACPA's got a new role on the horizon in aged care, and I think that's a whole new kettle of fish, because we haven't as a nation got the cost accounting, the experience, even the categorising very well developed or in use. So that's going to be another challenge, but also opportunity, and also to connect that in subacute care to the acute sector's financing as well.
And often it's not that the resourcing isn't there, it's just in 7 pots. And so you lose so much efficiency because people are doing a bit. By bringing an integrated model of funding that matches the clinical service delivery around a patient, that's where you maximise use of very scarce and getting far scarcer health dollars.
I think a lot of you have talked about, obviously, a reticence to go back to the way things were. You want to be moving forward and doing things more efficiently and taking some of these new developments on board. So in an environment where the financial resources are stretched, particularly due to COVID, do you believe that this current model of ABF funding can continue to face these new ways of working?
I think it can, but it needs to change. I mean, it needs to have the agility, and I mean, I guess this is why we're having this discussion, to be honest. And Alistair's committee and others working on this with IHACPA. But it can, but we need to be with our eyes open and not just think, well, post-COVID, we'll just go back to 2019 data and project forward, because what we do, where, how we do it, who does it, and the costs of that are very different, even the healthcare costs. And I will just throw in one other thing, which is capital cost. I know we're trying to move more into the community and out of hospital environments because it's a better place for the care to be delivered with better outcomes. But we still have a situation, I think, that is brewing around activity-based funding not covering the cost of capital. It's a sort of free good, which of course it isn't. And so as we try to look and innovate how we deliver and where did we deliver it, that's another issue I think needs to be on the horizon. Sorry, I keep throwing strange lobs in, but anyway.
No, I just wanted to
very holistically.
Yeah, and that,
I think the other opportunity is the National Health Reform Agreements, where, you know, this period up to 2025, there's a big focus on local planning and co-commissioning and really focusing on what the health priorities are for a population of 700,000 to 1 million Australians. And I think ABF's contribution to funding acute care, it needs to critically be linked in with a lot of the other funding sources that come in, particularly with mental health, aged care, chronic disease. All of those issues, I think, are much better planned across a population rather than within one organisation.
Yeah, I certainly agree with that, Claire. I think there's no doubt that that the issue of chronic care and the chronic comorbid patient in the community and the way in which ABF at the moment deals with that largely through the hospital sector needs to be reformed in a way that either provides appropriate bundles of care for maintenance of good health in the community, or has other funding options, either from a capitation perspective or otherwise, to keep patients in the community where they're actually safer, and where they take the pressure off our front door, our emergency departments, which are all too frequently used as an access point for non-urgent care, as instead of being used simply as an access point for actual urgent and emergent care.
Thanks so much for that. So obviously we've got a lot of interest, there are a lot of people watching this. So I'm wondering if you have any tips. How can health professionals at all levels help to improve clinical outcomes within their practice without compromising on things like efficiency in the delivery of high quality care, or vice versa?
I mean, generally low quality care costs more, actually. So just as a starter, I mean, I believe that whatever the setting, we need to have a more sophisticated use of data to support clinicians and teams. It isn't just one person; it's a team usually delivering the care. And, I guess there's different names given to it, but clinical practice analytics, using data in ways that is with a quality lens, and it is about an improvement lens rather than a compliance punitive lens. But actually having health professionals and the system managers involved in displaying that the outcomes data in a constructive way. And it isn't just the data, you then need to have the scaffolding around them to do the root cause analysis, if you like, or really understand, well, why are the outcomes different here to here? Or why does a particular surgeon have a different outcome in different rate in different settings? Because it's a broader team environment, so that there can be constructive change. But it needs to not be a blame sort of culture, and it needs to be one where there's constructive support in getting those better outcomes. And so I think we're a long way yet from harnessing all the forms of data that could contribute to that that culture and that sort of actions of improvement.
Thanks so much, Christine. Sorry, jump in there, Claire. Was that
yes, the other sleeper, and I don't hear people mention this much, is the patient engagement in their care and the impact that has on clinical outcomes. think we're often talking about clinicians, we're talking about hospitals, but in our world, a very large proportion of the outcome is very much related to patient literacy, their social, biopsychosocial backgrounds. There's no one size fits all for a particular patient. So I think where we really need to go in the next 5 years is really getting patients much more partnered and involved in their care. I've been involved in a couple of projects lately which have astonished me, that giving patients an app around their diabetes care or gestational diabetes can get a 95% engagement with patients who traditionally are possibly not as engaged in their care. And I think if we really want to get high quality outcomes, looking at getting much better engagement of patients and their families and carers would really help a very stretched health system to deliver the best outcomes.
Well, that sounds like a really positive development, and probably something that gives the patient a bit more agency and probably feel a bit more in control.
Absolutely.
So,
I love that, Claire. I tell my medical students that it's the person that has the starring role in their healthcare and their health decisions. And so we need to give them the best information and support in making those decisions, or have it available to them. So I might just throw in, so I've been lobbing things in here, but the My Health record, which I think is a person's most important health information, their own health information,
yes,
also needs to be further developed, accessible, and that literacy supported in that through the record, and people accessing it and using it.
Christine, you were talking about the importance of data, obviously, and getting access to it, using it in an appropriate way. So what sort of clinical or strategic reforms have you been able to implement in your own field or organisation as a result of broader access to hospital data?
Oh, well, I think, look, I've been an academic for a long time, and I'm involved in, in a technology company and aged care, particularly at the moment. I think the Sydney Children's Hospital experience, we've done some really important work out there. Memory care, which is memory project, which was about getting families their own data in looking after their children. I think there's a great pop-up palliative care service that use telehealth and information and data, and the Zero Childhood Cancer, which I mentioned earlier, which is a global effort of connecting people who are looking after children with rare cancers and having the genomic sequences, and by big data able to track down where particular rare cancer had a good outcome in the US somewhere, and being able to use that as a determinant of the treatment here. So many ways that data can be utilised. I would really like to see. I know the personal controlled electronic health record was another one of the Commission's recommendations, but I honestly think in the hands of individuals, if there was good timely information about their own care, errors wouldn't happen, and duplication and other things might not happen as much, but people would become more engaged and empowered, if you like, in their health and health decisions. So
and maybe just to follow up on that quickly, I mean, we know 90% of Australians have a MyHR, and they have all the basic medical quality and safety issues in there, but it's not opened as they move around the system. And so apart from pathology and radiology, which I think the private labs have been really good at accessing MyHR and making sure they're loaded up, it's a really unused resource. And I think probably the one plea I would have about efficiency in the health system, as Christine said, is that we get behind some incentivisation of use of MyHR across the sector and across the settings. That way people would get more value from it. We'd stop the duplication, particularly of pathology and radiology. And it's been set up to be as easy as possible to access. I just think let's spend a bit of time really getting focused on meaningful use.
Yep, agree.
Thank you so much for that, Claire. I've just got a question coming in from the audience, and I should say that I've been using some of the questions from the audience throughout our discussion, not exclusively, but they've certainly helped to inform this discussion. So I really appreciate audience engagement. At times we've had over 400 people joining us, so really great to see people getting involved, getting amongst it, and getting involved in this discussion. So here is one from the audience. Over the past couple of days, we've heard a lot about capitation funding, blending funding, integration of primary and secondary care. So there were two parts to this question. Firstly, is ABF as a funding model reaching end of life? And then also, should the H in IHACPA change from hospital to health?
Or health and aged care. Yeah, look, I don't think we need a single financing model. I think there's a role for activity-based funding in driving productivity, but the bundling, I will say we had a recommendation, Claire, as you know, about healthcare homes and bundled payments for people with chronic disease. I'm also old enough now, 4 decades ago, to have been head of planning in New South Wales Health, where we had a sophisticated capitation model for catchments of the different hospitals called the resource allocation formula. And so capitation, bundling, activity-based funding, fee-for-service have all got a role. It's how they're blended together. This is in my view anyway. There isn't one way of doing it. And the challenge, of course, is with multiple funders, how you do that in a way that doesn't, that gets the best outcomes and isn't a cost shifting exercise. So I know what you think, Claire or Ross or Alistair.
I mean, I agree, Christine. I think there's no doubt that that this will become a blended model, and I think the difficulty that we have is that ABF works very well, particularly in the hospital environment where there are relatively straightforward diagnoses. But as our population ages and our number of comorbidities increases, and as the care is delivered across the continuum of primary care and hospital care, it becomes more difficult to keep patients out of hospital with simply ABF. But I don't think its time is up. I think it will continue to be a very important part of the way in which we do hospital-based funding. But I agree. I think there's no doubt that the care of complex patients in the community with a series of comorbidities that are common lends itself to potentially a more bundled payment arrangement, and I don't think there's any doubt that that's one of the things on the agenda of the IHACPA, and something that we talk about regularly, because I think it's clearly something that works very well in particular courses of treatment, including areas like maternity, etc. But we haven't as yet fully adapted it for the heart failure, airways disease, renal failure patient, of which each one of us as physicians probably have 30 or 40 of those patients that we see very regularly with that combination, which potentially lends itself to effectively bundled payment, because in fact the treatment of some aspects of those sort of conditions are contraindicated in other aspects of those particular spectrum of conditions. So I think that's certainly something that we can do going forward. And to answer the second part of the question, I think health might be an appropriate word to put in there, and particularly some reference to the importance of delivery of healthcare and aged care.
And yes, I'd agree with both Alistair and Christine. Bundling is definitely critically important to the more complex patients, but also, as Alistair said, let's get on with something that's a bit easier, like maternity care. We used to have 83% of general practitioners in our area doing share care with our local maternity hospital. Now we've got 1,100 that are accredited and keen to share care, but the portion of GP share care has dropped down from 83% down to 40%. And yet we've got a midwifery shortage and difficulty keeping the labour wards open. So if we were just able to provide some sort of bundle payment to general practitioners to supplement the small Medicare funding, we would be able to offer women care that's free in the community, avoid them needing to go up repetitively to the hospital or to other clinics, and also link them in with the practice that's going to be looking after their new baby and their family and give a much better continuity of care and impact on women's mental health. So lots of places we could start. I just think we need to find one and get moving.
Yeah.
Claire, I just wanted to pick up there. You did at the very end there mention something that we haven't heard much of during this discussion, which by no means means it's not important, because of course it is incredibly important, and that's the area of mental health. That's a huge issue in healthcare funding. So I might start with you, Claire, since you did touch on it very briefly there at the end. How do you have any ideas of how to best fund and measure mental health services in the future?
Yeah, so if we got an hour, it's I've been in general practice 40 years. When I first started off, mental health consultations were not common. Now it's the fourth most common reason that someone will see a general practitioner in Australia. And I have patients with significant mental health issues who are 8 years old, as well as 102. Mental health, I think, is enmeshed in physical health, financial, housing, social issues, relationship issues, and employment. So it's an area I find very hard to just pluck out and stick to one side. And I think it's why I love having mental health being cared for within the community, because all those elements of support are available within our general practice and within the allied health team that work with us in the practice and in the community. We really need to look at it. Resilience is something we hear a lot about. We're trying to run programs in schools, we run programs in our practices, and it's I think mental health is our biggest challenge going forward. Prevention is critically important. Social media and its role, I think, can't be downplayed. And a comment a friend of mine made to me yesterday, who's now in her 60s, who said we've become a very angry society from the society she grew up in, where everyone, shrugged their shoulders and got on and weren't really quite so defensive and distressed about being let down. And she said we're actually much more demanding and much more unhappy. And maybe we as a culture need to look at the way we behave in workplaces, the way we behave in schools, the way we behave in the media. Is not what I would call valuing and supportive often, particularly in the middle of a political campaign. But I think mental health is massive. It's not just a health issue, it's a societal issue. And it's really time we pulled ourselves back and said there's something very significant going on in our culture, and we need to be much more focused strategically around how we deal with that.
Thank you so much, Claire, and a big thank you to all of our panellists. The clock is ticking, so I just want to thank Professor Christine Bennett, AO, Professor Claire Jackson, AM, Associate Professor Alistair Mcdonald, and Mr. Ross Sinclair. Thank you so much for your incredible contributions, a really lively, engaging debate, and I hope that our audience got a lot out of it. For now, though, I'd like to throw it over to James Downey to wrap up the session. Over to you.
Thanks very much, Janice, and thanks very much to all of our presenters, and thanks particularly to Christine for bearing with us on the technical issues. So that's the end of the panel, but please don't go away. One, on the way out of this session, can you please provide feedback on this session? And then please come back in 2 minutes' time, where I will be closing the conference and announcing the winners of the Best Presentation and Best Paper Awards. So I'll see you there very shortly.